When?
Hey everybody, this is Tony. We just intubated a mannequin here. This is the equivalent to a probably 26 to 28 week gestation infant. And we're going over pressures, we're going over rates, inspiratory times, expiratory times, CPAPing with a machine, and we've done quite a bit. Tiffany intubated this baby just now, by the way. So, I don't know if you can see with the camera, but if you zoom in, this little neonate that we have right here, we're getting good chest rise. So we are working with the airborne 750i. This is pneumatically powered. This is not the digital one, okay? And basically, if you set your I times between 0.35 and 0.4, you're gonna be good for pretty much any gestation infant. Your expiratory time is going to regulate your rate. So anywhere, you know, the lower your expiratory time, without doing fancy calculations, you know, a good one is just 0.75. But if you drop your expiratory time, the rate increases. Now you can calculate it or you can just count it, you know, but you're going to be anywhere between 40 and 60 breaths per minute as far as your ventilation rate on the airborne 750i. You have two cycles here, two different modes on this little transport ventilator. By the way, this right here is your entire unit, your ventilation unit. This is your ventilator right here. So this is going to be your bread and butter right here. You have cycle time and CPAP. Right now you can see I'm in the cycle mode, and I already did my ventilator pre-check, which I'll show you, you know, really quickly. But this is your PEEP or CPAP knob. It functions, you know, just the way you see it. To the left, increase, and to the right, decrease. And then you have your inspiratory pressure, your inspiratory time, and your expiratory time, and then your flow. So basically, let's just say I wanted to do some CPAP. Flip it to CPAP, and as you see, if I wanted to regulate my CPAP, yeah, right now we're kind of intubated. I don't know if you can see that, but there's my CPAP. Well, we'll show you something else here. Let's say you don't have a Neopuff and your Neopuff's out of commission and you got to use something for CPAP. You can use this little ventilator quickly. Just bring it up to the side of the bed, put it in CPAP mode, put your mask on, okay? And you can do your CPAP. So this has a lot of uses. This works very well with CPAP. So I can regulate my CPAP just like I can a Neopuff. Now, of course, you know, you can't ventilate like a Neopuff by covering the little hole for the inspiratory pressure on the Neopuff, but you can get CPAP. Now, have I ever gone to cycle mode non-invasively with a kid? I have tried it. It works. As you see, right now, I'm doing CPAP. I'm not intubated. I'm not intubated here. So I'm trying to replace the function of a CPAP with a ventilator circuit using the airborne, but it works. See, I'm getting chest rise. You get a seal. So if I'm in a situation where I have no Neopuff, you know, and I'm in a situation where I got, you know, I want to do some CPAP or ventilate. I have actually ventilated like this, and then I've switched. I've done my intubation, and after doing my intubation, I switched the mode. You know, of course, when we intubate, me and Tiffany were talking about it. I like to choke down the tube, put a little pressure on the throat at the same time as I'm inserting. My hand's coming toward the baby's head, say like this. You see that? Now I'm aiming down as I go in. You want to aim the laryngoscope down to prevent damage to the upper palate. So you want to aim it down. Aim down, choke down on it, very gently insert like that. Hold the baby's head as you're going in. You want to use your two hands at the beginning. This is what I call a one-person technique. And if you're going to do it by yourself, nobody can, see how my hand's coming toward the baby's head? Now right here I have full control of the baby. And I'm off the pallet right here. Okay? If you want to take a look at the camera, you can probably see the vocal cords on the top. We'll drop a truck through there. Anyway, so when I'm going in with the ET tube, I'm going in from the side and I'm deflecting off the laryngoscope blade. Once you do it a few times, you know, you're able to get the hang of it. See, got chest rise. So I just went from CPAP. Now I'm going to the ventilator. My pressures are all pre-checked, and as you see, my flows, you want to keep your flows about 8 to 9 liters per minute right there to get a good constant flow. You know, these are time cycle ventilators, so your run time on these things do really well. So for what we use it for, but basically we do have the blenders on the side, and we do have your flow meters. And when I do my check, I make sure that both tanks are full. And for example, if one tank runs out of oxygen, this is what you're going to hear. Anytime you hear that, it means either the air or the oxygen is completely out. Completely out. So again, if you hear that sound, you're going to be plugging into a wall real quick. But that's going to be your major alarm. And everybody's familiar with the tank replacement. I have noticed that these regulators on the oxygen, they leak. So when I do my check, I'll use the key, turn the regulator, get my PSI, and then I'll shut the tank down again and turn both of my valves off. So this little ventilator is pretty much complete right here because you can see everything that it does. Quick little tour. So again, if you're en route and you have to do CPAP, you can use the circuit. If you don't have a needle puff, take the vent inside the OR with you. In this case, I always have the vent settings good to go. I always had my vent settings figured out and calculated based on the gestational age of the baby. So if they tell me it's a 30-weeker or a 28-weeker or a 35-weeker, and I suspect there's going to be problems, I'm going to have my eye time between 0.35 and 40. You don't need to go any lower on your eye time, between 0.35 and 40. Now, of course, again, your expiratory time is going to regulate your rate without doing all the fancy calculations. So once you do your pre-check, you get to go prior to a delivery. Well, let's say we're already intubated. We have our baby in there. We're going to hook up. Once the baby's hooked up, you always want to recheck breath sounds again. In fact, anytime you move that kid, or even if the nurse goes in there and does this, I recheck the breath sounds. Why? Because the tube can be in place on these little ones like this, and they're extubated, just from a simple tilt of the head. So that's why I'm very careful when they start moving the kid around. I'm going to be very sure that tube's in place. So anytime you move the kid in or out, you want to recheck. And that's basically it. Now we're good to go. It looks real, doesn't it? Well, if we